Hi, good afternoon, everyone. Welcome. My name is Jennifer McKinnon. I'm the Primary Care Officer with the Northeast Local Health Integration Network. It's 12 o'clock, so I know that we will still have some people joining us, but given our limited time today for our presentation, we'll start, and we will hopefully get everyone signed in as soon as possible. So I'd like to thank everyone today for taking your time out of your busy schedule to join us for this webinar on sub-region work. We have not used a webinar application that frequently to communicate with our stakeholders, so today's session is not only an opportunity for us to reach a wider audience in a new way, but to hear from you after the session on how you found this technology as a vehicle for communicating with you. Was it effective? We would like to know your thoughts after today's session. So before we start, there are a couple of housekeeping items that I'd like to share with you. As a result of having approximately 250 people registered today for this webinar, all telephone lines are muted except ours. This avoids the noise of signing in and out and our happy barking pets in the background and any other noises. So you will have received a copy of today's presentation in advance in both English and French. We do hope that this will mitigate any technical issues that might crop up, and fingers are crossed that we will not actually face any of those issues today. We will accept questions in the chat box of the webinar, which is located on the left-hand side of your screen. We will try our best to answer all questions in our 45-minute time frame, both those pre-submitted as well as those submitted as the presentation unfolds. While today's presentation is in English, we will take questions in both English and French through the webinar chat box. And we are also recording today's webinar for people who are unable to attend today so they can listen at a later time. Finally, an evaluation will be sent to you immediately following today's webinar for your feedback. We encourage you to please let us know your thoughts about both the sub-region work that we have underway as well as the use of the webinar format for future conversations with you. So today's webinar is an opportunity for us to provide you information about the work underway on sub-regions in the Northeast LHIN and for you to provide us feedback and comments to ensure that we're moving in the right direction. The purpose of today's webinar is to focus on the geography of our proposed subregions, not on specific but valid service concerns requiring attention in our LHIN that you may have. LHIN subregions are a key feature of the proposed Patients First strategy. Subregions are not boundaries and would not act as a barrier for patients to access services, but instead to help LHINs better plan, integrate, and improve performance of health services. We know that the best way to support people's health is to ensure that they have the supports they require close to home when they need them. So I'm very happy this afternoon to introduce to you Terry Tilichek, Senior Director of Policy and Health System Planning with the Northeast LHIN, who will be leading the presentation. So thank you, Terry, and welcome.
Thanks, Jennifer. And thank you, Josh Willard, who's here with us today, our Communications Officer, who takes care of everything multimedia for us, including supporting today's webinar. We also have Manikla Palm with us, who will be assisting us with any French language issues that come up with respect to translation. And thank you all again for attending this webinar this afternoon. I know schedules are very busy this time of year as we get back into the thick of things after taking kids back to school. This is a very demanding and challenging time for us in the industry, but it's also a time of significant opportunity for us to come together as a system of healthcare leaders, administrators, and frontline workers to create the change necessary to support the demographic shift that we're witnessing right now. Think about it for a moment. The median age of Canadians, the age that divides the population in half, was 27 years in 1956, and in 2014 was 40, and is projected to increase to 47 over the next 40 years. Think about life expectancy. 1956, it was 68 years for men and 73 for women. 2005, that increased 10 years for each men and women, for males and females. So we're living longer. And then finally, if we think about the aging of the population, We know that in 1956, 7.7% of the population was 65 years of age and over, and in 2006, these are Canadian numbers, was 13.7. And we know that for us specifically in Ontario, it was 16% in 2015 and is projected to increase, like the Canadian average, 25% over the next several decades. So we have a system, or we have a demographic in Canada and in Ontario that has changed since the introduction of Medicare in the 50s. And Medicare was established and supported a much younger population, and we did an awesome job of that. And we've got a strong acute care system that we've built up over the subsequent decades, which is exactly what we needed to support the Canadian population with a median age of 27. But now, as we see the demographic shift, we've got a population that, while still requiring acute care, needs other types of services and a different type of healthcare system to support them. So when we think about the demography in Canada and in Ontario, when you add in all of the other factors associated with delivering healthcare in northeastern Ontario, you can see that we have a very challenging time ahead of us to try and indeed support our residents in this way. We've got a very dispersed geography, a very diverse population, and we've got health behaviors that, unfortunately, when we compare it to the rest of the province, shows that we have a little bit of work to do. Here we've got rates of smoking, drinking, and overweight and obesity. So given that kind of context and that background, how are we going to, I think the challenge for us is figuring out how we're going to work together to meet the needs of our population who are requiring a more coordinated approach to care in the community, particularly when we think about home and community care and primary care, but also other areas of service provision and need, for example, mental health and addictions. So how are we going to do this? Well, one of the things that we do as a regional health organization is we publish strategic directions every 3 years, and all of you who are involved in terms of working with the LHIN day in and day out know that the Integrated Health Service Plan is something that's embedded in our legislation, and we need to establish one every 3 years. So this is our fourth Integrated Health Service Plan. And by now, I would assume you are well aware of the 3 priorities that are going to be guiding our work over the coming years. So we're working hard with you, our stakeholders, to improve access, coordination, and ensure the system is sustainable. So we're working on reducing wait times, as an example, for surgical and diagnostic procedures, developing more coordinated care plans for patients with complex needs, and working on strategies to better support frail seniors in their homes and in their communities. So those are the 3 key strategic priorities we're using to guide our work over the coming 3 years. And these priorities will continue to guide us. At the same time, we're undergoing changes as outlined in Patients First. So you're all familiar now with the December 17th release of the discussion paper, and it focuses the government's thinking at that time in terms of the next evolution of the healthcare system in the province of Ontario. So we're looking at a population health focus, looking at integration, improving access to primary care, standardizing and strengthening home and community care, and strengthening population and public health. Now, some will say, well, why don't we just add more money to the healthcare system and that will fix the challenges that we have for us? But there are others who say, in fact, we have a fairly well-financed healthcare system in the province of Ontario. If you look at the 2014 report from Ontario's Institute for Competitiveness and Prosperity entitled Building Better Care, Policy Opportunities for Ontario, they showed that Ontario already has a costly healthcare system with total per capita spending 33% above the OECD average And compared to international peers that spend less, Ontario does not achieve higher value for healthcare. And they specifically point out the areas of access to care, wait times, and patient safety. So based on this, we know we can do better, and Patients First is the framework that's going to assist us to move ahead. So what does Patient First talk about? Well, it talks about a number of areas of focus, including effective integration of services and greater equity. It talks about timely access and better integration of primary care, more consistent and accessible home and community care, stronger links to population and public health, and, of course, a focus on the Indigenous peoples of Ontario and Francophones. We know that Indigenous people of Ontario do not always get the best service that they require, and for Francophones, a requirement to receive services in their mother tongue, in French. So those 5 areas really encapsulate the strategic direction that is in Patients First, published back in December. Today, though, we're speaking specifically about subregions. That was the topic for the webinar. So within the Patients First document, the first proposal talks about addressing a more effective integration of services and greater equity, and proposes to provide care that is more integrated and responsive to local needs, makes LHINs responsible and accountable for all health service planning and performance, and identify smaller regions as part of each LHIN to be the focal point for local planning and service management and delivery. So LHINs would be asked to identify smaller geographic areas within their regions, or LHIN subregions as we're coming to call them, that reflect community geography, such as the health links. Such LHIN subregions would be the focus for strengthening, coordinating, and integrating primary health care, as well as more fully integrating primary care with home and community care, and ultimately fulfilling the clinical coordination responsibilities provided by the CCAC. The LHIN subregions would take the lead in integrating primary care with home and community care. So what is a subregion? Well, a subregion is really an area within a local health integration network. It's the focal point for local planning and a focal point for performance monitoring and management. So each of the 14 LHINs from across the province have been asked to develop plans that identify what their subregions should look like. We've been working on this now for some time and have had a number of drafts that we have taken out for engagement, and I'll talk a little bit more about that in a few minutes. I would like to say, though, that when we think about the subregion construct, it's really not that new and unique for us here in northeastern Ontario, and maybe for some of the other LHINs across the province. We've really divided up our geography like this, certainly in the 10 years that the LHINs have been in place fulfilling their mandate, but also previously to that under the old DHC system, because it just made sense in terms of the way that the population has grown in clusters, if you like, urban and rural, across the 400 and some odd thousand square kilometers, and services have developed around those population clusters. And so certainly when the LHINs came on board and took their mandate in 2007, we immediately began to look at how administratively we could work with the system in order to plan and integrate based on some subregions. And so at one point we had I think it was 6 CEO tables that focused on the population in their respective catchment area and prepared plans. Probably their biggest work that they did back then was looking at the program related to increased supports and services out in the community, aging at home. And so it's something that I think we've been fairly comfortable with in the Northeast for some time. So this new iteration, if you like, in terms of how we're going to be looking at doing our planning in the region, the sub-region. What will it do exactly? It's going to support system-level planning and accountability conversations at a smaller geographic level than the LHINs. It's going to allow providers to more closely work together. Coordination should be supported at the sub-region level. Increase health and wellness. Equity is a very important element of our decision making and of the kind of lens that we're going to be looking at doing our health system planning in the future. But what subregions won't do, as LHINs don't do, and that is limit the movement of patients in any way in terms of where they receive their services. So again, just like the LHIN and the LHISIA legislation wasn't about changing referral patterns, nor is the sub-region concept or construct. As noted by the Deputy on the September 7th webinar, there are a number of issues that need to be planned for the sub-region basis that he articulated and outlined, and those were improved access to mental health and addiction services, the smooth transition between primary care and home and community care, improved communication between points of the system, and planning for future health human resource needs in primary care and home and community care. So it's really that kind of lens that we're going to be looking through in continuing to do our planning to build the system that we need to in order to support that demographic shift I talked about earlier. So how did we get here? Well, as we normally do when we're looking at any initiative or issue in the healthcare system, we looked at data and we went about doing some engagements, and today is part of that engagement strategy. So we looked at geography, we looked at electoral districts, public health unit boundaries, existing LHIN boundaries, DSAB boundaries. We looked at how patients move through the system in terms of hospital usage, both acute care services and emergency department utilization, but also secondary and tertiary care as well, because we know we've got 25 hospitals across the region, and if somebody's presenting with a healthcare need that outstrips the resources of a particular institution, they move on to another institution. So looking at secondary and tertiary care was part of that process as well. In addition, looking at demographics, of course, social determinants of health, and some other considerations like how people move about the region for other reasons, like shopping patterns, etc. So we've been busy working away, looking at the data, analyzing the data, and engaging in with stakeholders to refine these planning areas. Some of the engagements that we have undertaken to date include the Nipissing-Temiskaming Hub Planning Day, Health Professional Advisory Council, French Language Planning Entity, our Aboriginal Committee as well, the Northern Ontario Service Deliverers Association, our System Advisory Committee, Primary Care. We were in Elliott Lake recently, a few weeks ago, speaking with that community. There are a few, as you'll see when we get there, communities and geographies within the Northeast region that we've tweaked a little bit as a result of the data that we have analyzed and the engagements that have taken place. So, what are the subregions in the Northeast LHIN? Well, to, I think, no one's surprise, they look like this. Not that different from the hub model that we've been using administratively in northeastern Ontario over the last 5 years or so to do our planning. So we've got 5 subregions we are proposing. Algoma subregion, Cochrane subregion, James Bay Coast, Nipissing-Temiskaming, and Sudbury, Manitou, and Parry Sound. So these 5 subregions have taken into consideration, as I noted, hospital referral patterns where people are sent for secondary care. Each subregion has one hub hospital in it. Primary care patterns where people receive primary care services. Also important for us when we're doing and setting the foundation for our further healthcare planning have to do with data. And so we needed to know that we would have the ability to generate data and performance indicators that do not identify individual patients and are replicable. We can repeat them, and that they're statistically viable. So basically looking at populations that are greater than 50,000. And of course, use of other health services that I mentioned earlier. And we certainly recognize that finding the one right set of boundaries for subregions is not easy. There are many regional providers who provide services over a range of subregions or primary care groups. DSABs and health units, for example, each provide direct care to people in the Northeast LHIN, and they have different boundaries to what is proposed. Each have been reviewed to see the fit, and some examples where things differ include, for example, the Northeast LHIN feels James Bay Coast should really be its own planning entity due to the unique cultural and geographic differences there. But the James Bay Coast is part of the Porcupine Health Unit, covering Cochrane District and the James Bay, and the Cochrane DSAB does not cover all of the James Bay Coast. Other differences, some health unit and DSABs do not have hub hospitals. For example, Temiskaming DSAB and Temiskaming Health Unit do not have a hub hospital, so referral patterns to healthcare are not aligned there. And then we can look at the overlap between LHINs. The Northwestern Health Unit covers part of the Northeast LHIN territory. Other communities on the border of the Northeast LHIN may actually be better served by planning entities in other LHINs. So if we think about Martin Falls, it's very close to the Northwest LHIN, and South Algonquin as another example, close to Champlain. So we're never going to get all the borders and boundaries perfect. And whenever you start drawing circles around things, there's always those outliers that we have to take into consideration. But it's a work in progress, and at the end of the day, what matters is an improved patient care system that is delivering services that are required for that specific population, and I think improving the patient experience through that process. The subregions are really about providing a focal point for local integration and coordination, and one that's going to help us focus on overall improvement of population health. So, in terms of trying to display this on a single page, I know Jennifer and her colleagues here have been working for many months on this process and have provided for us, I think, a good starting place for us to begin to get our language correct around what the subregion structure means to us across the region. And so on this slide, you'll see that across the top, we have the 5 subregions. They're in gray. Below that, we've got 14 health links. And then below that, we've got 26 what we're calling primary care groups. Because of the large geography of the Northeast LHIN, we recognize that there really are 26 unique communities where healthcare and other services are provided, particularly when we think about primary care. And so, as a result, we're just trying to lay out kind of those layers of focus that we will be working with our communities to engage on improving healthcare and care coordination and access. And it's important, I think, that we get common definition on what the subregions, health links, and primary care groups really mean. Talked about subregion. Health links, I think, for the stakeholders on the line in the healthcare system, you'll be very familiar with health links. Really about bringing stakeholders and communities together to create individualized care plans for our most complex patients. And HealthLinks will align with subregions because of assessment of local needs, improved communication with local partners, and performance measurements that are underway with the complex patients. Primary care groups is really a nomenclature that we're using to talk about how primary care is delivered around a smaller subsection of the population. And so, as you see on the slide, Patients First speaks to LHINs having responsibility for primary care planning and performance improvement. We've got clinical leaders who are identified in Patients First. We kind of went out perhaps a little bit ahead of the province just because, again, of our reality of northeastern Ontario when we selected our first, well, not our first actually, I think it was our second primary care lead, first being Dr. Al McLean and then Paul Preston. It was clear that there was no way that a single individual was going to be able to go around northeastern Ontario and engage with primary care practitioners, and so the LHIN put its resources on the table and established primary care leads to support Dr. Preston right across the region. And so we have Dr. Yves Raymond up in the Cochrane area. We have, of course, Dr. Paul Preston, who is our primary care lead in the Nipissing-Temiskaming area, and then Dr. Farah and Dr. Stewart for Algoma. We've just recently recruited Dr. Jason Sutherland for the Sudbury lead position. It was Dr. Rena Dat, who has moved on to our quality lead clinical position. And then, of course, we have Barb Kiley, who's a nurse practitioner and was brought on in the early days to help us with diabetes and primary care. So we've got a team of clinicians that have been working for the last few years in doing community engagements for primary care. And I think this is an area where it really lends itself to the importance of really understanding your local community. So when we think about the work that we have ahead of us, human resource planning, we've been working away at really trying to understand what that primary care environment looks like right across the region. And Dr. Preston has been leading this for us, taking the North Bay area as the first kind of focal point of this review. So he grabbed the CPSO data from the province, which identified 75 physicians as actively working in the North Bay area. And by the time Dr. Preston was done going through that list, and Dr. Preston has been in the community for quite some time and pretty well knows every primary care practitioner there, or at least from the physician side of things, actually that 75 turned into about an estimated 31 FTEs. So he identified some had passed away, some had moved away, some had retired, others were doing additional activities related to ED coverage, specialization in addictions. And so really the complement for delivering primary care to a rostered population was about 31. So for primary care, it's really about working at a sub-community level to understand the primary care demand and the primary care supply. And so we've kind of mapped out on our chart what those primary care groupings, we could almost call them primary care groupings across the region and what they look like. So that provides you with a level of detail kind of on those three levels of sub-region, health links, and primary care groups or primary care groupings. The next set of slides just provide you a little bit more detail, again focusing on each of the sub-regions and providing information related to primary care as we understand it today, being on the ground and supplying services. We're also obviously and have developed for each of the sub-regions a full overview, if you like, of all of the health services and corporations delivering services within each of the sub-regions. So this is the Algoma sub-region with the health links divided. underneath. This is the Cochrane subregion. And we've got the North Cochrane Health Link, Mixed Group Health Link, Timmins Health Link, and Chapleau Health Link. And I should mention that not all of these health links are up and running and are at a full state of maturity right now. We have a few of them, such as the Sioux, Timmins, Temiskaming, pardon me, that got out of the gate a little early, and others are hitting stride. We've got Sudbury coming on board and having an event coming up in the next week or so, announcing that health link. And others are really in the embryonic stage, and we're just beginning to work with those communities to support them in that regard. Nipissing-Temiskaming subregion, Sudbury, Manitoulin, Parry Sound subregion. And I should comment as well when we think about subregions on Parry Sound, because it's one of those populations that sits on the edge of one LHIN, on the edge of two LHINs actually. And when we look at the referral population for Parry Sound, there really is a split in terms of the types of services, perhaps we'd say secondary or tertiary services in some cases, where the population goes south and some comes north to Sudbury. So that's an ongoing discussion I think that we'll be having about how best to align the Parry Sound area. And then finally, the James and Hudson Bay Coast, and again, very unique for those of you who have either worked up there or traveled up there. You know that there are many issues that require focused attention. And I know through our lead, Carol Filden Jolette, who travels up there quite frequently, I think we're starting to, bring the supports and conversation to a point where hopefully we're going to see some significant improvements in service delivery up on the James Bay Coast. Not an easy area to service. So I've rambled on long enough. The next slide really just talks about next steps related to the sub-region development. We're going to be incorporating feedback from the engagements and continue to look at data as people question whether this geography should be here or there. And all 14 LHINs have been requested to submit their planning documents to the ministry by September 30th, and we're well on our way to do that. Before I turn it back to Jennifer, I just think it's important to note that this sub-region concept is not dependent on the passage of any legislation. I think it's just become part of the conversation about how to better improve our planning and, more importantly, our coordination and integration of the system, that you need to do it on geographies that are smaller than the 14 LHINs. And so we will continue as a LHIN body, 14 of us, to move down that path irrespective of a passage of a particular piece of legislation. And I think for us, it maybe doesn't seem like that big of a deal because we've been doing it for at least 10 years now. So I hope that was informative. For some of you, it may have been information you may have seen already. But I think it is important for us to communicate as broadly as we can through a webinar of like this to ensure that we've got a clear, consistent communication going out across the field. So with that, I'll turn it back to Jennifer.
Okay, thank you very much, Terry. I appreciate your time in providing us with the presentation today. So we do have around 10 minutes left in our webinar, and so we left this aside to answer some questions, and thank you for all of you who did pre-submit questions for us. And so I'm going to be going through questions right now. So the first question that we had received was around, will there be an increase in administrative positions and costs? Will there be closures of existing facilities and or amalgamations? And how does patient care get affected? So one of the outcomes of planning based on sub-region geography is to improve the patient care. So sub-regions, as Terry said, are not boundaries and would not act as barriers to patients receiving services. Sub-regions and the work that we're doing are really intended to serve as a means to help LHINs identify and respond to population needs and to better plan, integrate, and improve the performance of health services. So one of the next steps from this work is to have some facilitated sessions with providers, patients, and partners in the sub-region geographies so that we can build collaboratives across the LHIN. An example of this work has already begun in the Nipissing and Temiskaming sub-region, where I think it was in May we held a facilitated meeting for the day, and a sub-region health leadership council has actually been recommended to be established for this area. This leadership council will be made up of representatives of the various health service organizations, patients, and partners. The Leadership Council will meet regularly to discuss, strategize, make recommendations, and implement solutions that help to create a more patient-focused and integrated system of care for people living in that sub-region. We also received a question for the organizations within a sub-hub. Has there been any thought as to what the reporting structure will look like? What will happen with all current executive directors and administrative teams? And will there be dissolution of the boards of directors, and what is that anticipated timeframe? So again, at this point, the purpose of our sub-regions, they're really intended to serve as a means to help LHINs identify and respond to population needs and to better plan, integrate, and improve performance of health services. Health service providers who do receive funding from the Northeast LHIN will still have reporting arrangements through their accountability agreements for funding and performance directly to the LHIN. That isn't going to change as a result of sub-region and planning that goes around it. Again, using the example of the Nipissing-Temiskaming Sub-Region Health Leadership Council, the Council's terms of reference is recommending that it be accountable to implement a 2-year work plan that includes deliverables with both patient and system outcomes. The Council would hold full responsibility for implementing the plan. What are the implications of this new structure on recruitment and retention efforts for primary care and home care? It's another question that was asked. Again, going back to the concept, the intent of the sub-region planning is to improve patient care through better planning, coordination, and communication between health service providers, public health, and primary care. So we have recognized that primary care is focused at that much more local level than the sub-regions that we're talking about, and you know, for the many reasons that we have gone with the bigger sub-regions, we do recognize that primary care has to be a much more local conversation. So that is why we have pulled aside these 26 primary care groups, and potentially more as we begin the conversations in all of our communities. These primary care groups, they really do recognize that these smaller geographies, the primary care providers do work together locally for the care of their patients in groups of people. So recruitment and retention of primary care providers, as well as home care providers, that's that aspect of local planning that we want to have, and we must understand so that we can best support our communities. We do know very clearly that primary care unattachment rates are a problem for us. The example Terry gave around Dr. Preston's work and understanding, if we have 75 physicians, but we actually have 31 providing primary care in that community, it is an area that we do have to understand in going forward. Will the efforts of the CCAC staff in aligning services, including reducing redundancies, as well as enhancing our network participation of various members of the healthcare system, be continued? So the short answer to that is yes. We would hope that this group of professionals who are very dedicated to their patients and improving the healthcare system continue this work going forward. A question from the Northern Ontario Service Delivery Association. They did motion on behalf of 144 northern municipalities that sub-LHIN boundaries be aligned to the municipal district boundaries used by the Social Services Board. So we have very much looked at DSAB as well as public health unit boundaries in the work that we've done. And what we would say is sub-regions, regardless of their geographic boundaries, will be expected to include an equity lens in the work going forward. And currently DSAB's public health units and the former LHIN hubs, we all are based on differing geographies. Patients First includes linkages between medical officers of health and LHINs to plan for population health needs. So, and really the data that we have access to, particularly for primary care in hospitals, shows us that our healthcare patterns really do align to 5 geographic subregions. So, District Social Services Administration Boards and public health units who do provide services and focus on the social determinants of health will be important partners at all of our tables going forward in the work that we have to do. There was another question regarding a primary care clinic in Thessalon with a satellite location in Echo Bay and concerns around being in 2 subregions. We can confirm that Thessalon and Echo Bay are both in the proposed Algoma subregion going forward. So we have a couple more minutes. I noticed that there are a few questions that have come up from our webinar. There was one around what are the standardized indicators for performance. So the Northeast LHIN does have an accountability agreement with the Ministry of Health called the Ministry LHIN Accountability Agreement. Thank you, Terry. There are 14 indicators that are part of that. That is available on our website for anybody to look at. We do have, as part of that, particular indicators that are now coming on called monitoring indicators that are very specific to health links and primary care, actually. That include things such as readmission to hospital within 30 days of discharge, follow-up with primary care providers within 7 days of discharge, certain readmissions as a result of certain conditions. We recognize that there are problems with some of those indicators, that they don't necessarily reflect the realities of our Northeastern Ontario experience. And at this point, so there are no targets for those, but those will be the monitoring indicators that we have going forward. There's a second one, another question. How is the LHIN looking at the RNPGA funded groups that need to serve all patients, even if they haven't been rostered? Rostered numbers don't match the number of patients we serve, as well as the visitors to the community needing services. So physician compensation will not be something that would be transferred to the LHINs as part of Patients First. So that, RNPGAs, for those of you who are unfamiliar, are Rural Northern Physician Group Agreements. And so that would remain, as with all physician compensation, with the ministry. I think that where the LHIN plays the role is in supporting the conversations locally with the primary care groups to help everyone understand sort of the true realities of what's going on in primary care, so that we can have these conversations with the ministry to help understand how we can help our populations to have 100% of coverage of primary care. For those people who do want to have access to primary care, we want to see that people do have that ability to have that care. So I hope that answers that question. In the mapping that's been done, another question from a webinar, in the mapping that has been done in the primary care groupings, has FLS capacity been mapped as well? The information does not appear on the slide presented. That's a great question, and it's an area that we are struggling with. So one of the things which we didn't really talk about is the access to primary care information is very difficult. A lot of it has been a lot of our own sort of looking and searching to try and gather that information. So we do know that we do have francophone health centers that are in 5 of our communities. There has been some work, again, when we think about that primary care group and that community, and trying to understand, even amongst the providers, the physicians in those communities, who is able to provide French language services to patients, who is not. So certainly from a planning perspective, we would want to ensure that that piece is captured going forward, and so that we are able to ensure that we're knowledgeable and providing the care to the services of the patients in that community. So again, I hope that answered that question. Okay. And then I'm going to say as our last question, because we are right at the end of our time frame, Magnetawan, Burkes Falls, Sundridge, and South River are in the Almaguin Highlands, Why has Magnetowan been put in Sudbury-Manitoulin subgroup while Brooks Falls, etc., have been put in a different subgroup? Our areas have little in common with either of them. We'd love a chance to talk about this, and thank you for that. This is exactly the type of feedback that we are looking for, because we would like to talk to you about that as well, Erica. It's basically, when we've looked at all of our communities, it has been around what the data is telling us, but it's not necessarily the community context that we've been able to get from that information. And so I'm happy to follow up with you about that for a further conversation, but really what has driven that has been that our direction has been the patient usage data is showing us that that's the case. Okay, so thank you very much. I am appreciative that our time is up for today. It's 12:45. Thank you so much. We do look forward to your continued comments. There will be, as I said before, an evaluation that will be forwarded to you after today's session. And please let us know how we did, how the webinar format worked for you. And thank you very much to Terry, to Monique and Josh, who are with us today in Sudbury providing this.